In the second part of this project, we will talk about the preparation, cleaning, irrigation, and obturation. One of the most important steps in endodontics is the preparation of canals. On the other hand, is also one of the most critical steps during which most often occur many mistakes such as instrument fractures, perforations, insufficient ability to clean the canal completely, and other. As we know that the purpose of endodontic treatments is to remove as much as possible the content from the endodontic space of the tooth, such as organic tissue, inorganic tissue, debris, bacteria, etc. To achieve this in the easiest, minimal invasive and efficient way, I will present you a fantastic system, very special and different from other systems. It is about the XP-endo Shaper instrument. This instrument has a special design which is composed of a booster tip while its body is curved. The taper of XP-endo Shaper is 0.1, but it has the ability to prepare the canal by size ISO 15 to 13, due to ability of expansion in the canal. Exactly from this ability, this instrument conveys very well the anatomy of the canal without removing the healthy parts of the dentin. Therefore, it is called three-dimensional preparation. Also enables the preparation of narrow and hidden anatomical spaces. This instrument causes minimal stress on dentin walls and minimal stress on the instrument. If we want to prepare the canals in three-dimensional way, maintaining the healthy structure of the tooth but removing to the maximum the content of the endodontic systems of the teeth, is exactly this instrument that meets our clinical requirements. From many other studies, here we have a study that has been done regarding the preparation of oval-shaped root canals in mandibular molars using night-eye rotary instruments, a microcomputed tomography study. I suggest you to read the whole article to get all the information and details about the study, but here I will just mention the result of study, which concludes that the mean untreated areas ranged from 59.6% to 79.9%. And this is worrying. So I said earlier that the XP-endo Shaper instrument is a special instrument and offers much more than the other instruments we have on the market. In the next study, we have the mesial roots of mandibular first molar, regarding the preparation of canals with rotating instruments. In these images, we see in green the unprepared areas, while in red are the prepared areas. Also, when looking at the cross-section, that conventional rotary or reciprocating night-eye instruments prepare a round space, but cannot reach and clean the not regular space. So this is the problem we are going to solve with three-dimensional instruments like XP-endo Shaper and XP-endo Finisher. Whilst we are at this point, I will present a video where the difference between two-dimensional and three-dimensional instrumentation is clearly seen. On the right side we have reciprocal movements, while on the left side we have the XP-endo Shaper, which rotates and hits the canal walls in three-dimensional plan. In this video, the same protocol is used for the two types of preparation, and in the end the difference is obvious that with XP-endo Shaper the cleaning of endodontic spaces is much better and more efficient. Now let's see the protocol of use of this system. We mentioned above that it is very important before glide path to perform the opening of orifices up to 3 or 4 millimeters. It depends on the case with BioRace 0. This is not always necessary in easy cases, but coronal opening helps a lot in more complex cases. Then, either manually or rotary, we have to perform the canal expanding up to the size of ISO 15. This is a condition that must be met to continue further with XP-endo Shaper. Not to be forgotten that irrigation should be done all the time. XP-endo Shaper works on a rotating basis 800 to 1000 rotations per minute. Initially, it is very important that the cavity to be filled with sodium hypochlorite and then with the XP-endo Shaper instrument to enter the canals and perform some short movements in the apical and coronal direction, 3 to 5 movements, usually in the apical direction, until we reach the full length of the canal. If we have problem to reach the full working length of the canal, we need to recapitulate with irrigation and the file ISO 15. After we have reached the full length of the canal, we irrigate the canal again and re-enter with the XP-endo Shaper instrument and perform 15 movements along the full length of the canal. This is relative because we need to assess if there is still a need to clean the canals, depends on the case. So this is a one-file endo system. As we see, it is a very simple and efficient system. Now let's see a clinical case of using XP-endo Shaper. And now let's talk about the second instrument called XP-endo Finisher and see some of its specifications. This instrument is dedicated for cleaning the root canal wall regions which have not been reached by the root canal preparation to mechanically remove debris packed with microbes. XP-endo Finisher has an interesting shape which is curved at the top with a straight body and has a conicity of 0.1 for its entire length. It has fantastic ability to clear spaces which are inaccessible with other instruments. Very good expansive ability, up to 100 more than its thickness. To see all these features we mentioned, I will present another study that has been realized regarding the irrigation protocol and final cleaning ability by comparing 4 types of cleaning systems: the apical, positive pressure, self-adjusting file, passive ultrasonic irrigation, and XP-endo Finisher. And look at the 3 separated colored sections: before preparation, after preparation, and after irrigation. You can clearly see in these images that the XP-endo Finisher system and the passive ultrasonic irrigation system have given much better results compared to other systems in cleaning endodontic systems. And here we have the result of study which says reduction of accumulated hard tissue debris was observed in all groups after the final irrigation protocol. Overall, passive ultrasonic irrigation and XP-endo Finisher groups had higher mean percentage reductions of accumulated hard tissue debris than apical, positive pressure, and self-adjusting file. Now let's see the irrigation protocol. All we need to make a proper irrigation and cleaning of canals is that what you see on the slide: dual rinse, XP-endo Finisher, and finally irriflex. We will talk about each technology and its characteristics separately. Here are some images of how the irrigation liquid is prepared. We fill 10 milliliters of sodium hypochlorite into the metal recipient, then mix it with the capsule powder for maximum 2 minutes until it is well dissolved, and then pull it into an irrigation syringe. The video shows how the mixing of dual rinse with sodium hypochlorite is done by your dental assistant. Who can do this? Well, you place the rubidam, for example. Of course, you can also use sodium hypochlorite and EDTA. However, studies show that you get better results when using dual rinse. I suggest you read these studies to better understand the advantages. The main advantage is that dual rinse will have a decalcification effect during the whole irrigation time. Therefore, you avoid the smear layer and sodium hypochlorite can work more efficiently. The result is a better disinfection and the less erosion of dentinal walls. Now I will talk something about the needle collet irriflex. For most of you it is known, while for those who don't know, the irriflex needle is made of a soft polypropylene body which is dentin friendly and that can easily adapt to every root canal anatomy. Go as close to the apex and irrigate areas once impossible to reach. This is really a very special needle and different from other needles. The needle had a luer lock connection. It is 27 millimeters long and the depth marks are from 18 millimeters to 22 millimeters. It has 0.4 taper and 13 gauging size at the tip. Back-to-back two-side vent designs secures a balanced irrigation volume and a better control of the root canal irrigation. You can even put a rubber stop on irriflex to better control the working length. We said that the irriflex is a special needle and different from the others. This is best proved by this video done by Dr. Riccardo Tonini, where the difference between irriflex and other metal needles is clearly seen, especially when we have curved canals to treat. Okay, we have talked about dual rinse and irriflex. Let's see now something about the incredible XP-endo Finisher, which is dedicated for cleaning and removal of hard tissue. The instrument is supplied in a sterile package and has a plastic which is marked in millimeters to measure the length of the needle. Insert XP-endo Finisher into your motor handpiece. Then we need to set the desired length, taking the rubber stop and the plastic cover at the same time. After we have set the desired length, we just take out the instrument of the plastic cover. Inserting the instrument into the canal is sometimes challenging. Look at these images. Inserting the instrument should be done in such a way that its tip is directed to the outer walls of the canals. Otherwise, we will have difficulty inserting the instrument into the canals. That means that the tip of the instrument must always be turned towards the outer walls of the cavity and not towards the bifurcation. After inserting XP-endo Finisher into the canal pre-filled with sodium hypochlorite, we perform movements in the apical coronal direction for the entire length of the canals in the duration of 1 minute per canal. You can move your motor handpiece out of the axis a little bit, for example, north, south, east, west, each time for 15 seconds to reach all the spaces. It is preferable to use XP-endo Finisher with sodium hypochlorite for 13 seconds and 13 seconds with EDTA. Or if we use dual rinse solution, then we stay for a 1 minute in the canals. This is of course relative, it depends on the case that we are treating. The dentist decides whether the procedure needs to be repeated or not. And now let's see all these steps in a clinical case. The root canal preparation, cleaning, and most importantly disinfection of the root canals are finished. The challenge is to fill the canals in a three-dimensional way, to create a hermetic, long-lasting obturation. This is a challenging step because of the complex root canal anatomy, but luckily modern bioceramics simplify the procedure a lot. To better understand the problem of obturation, I will briefly present a clinical case. The maxillary left second molar, which was treated endodontically. The patient had complaints, pain, and even took antibiotics due to sinusitis caused by this tooth. The patient was referred to us, and on the initial X-ray, the endodontic treatment actually looked good. The patient was so frustrated and refused to try a retreatment of the tooth and insist on extraction. After we extracted the tooth and I took it to analyze it, and as you can see in this picture, the apical part was not well obturated, with a gutta percha cone overextending over the apex. We prepared cross-section of the tooth to see the filling of the canals at different levels of the roots. As you can see in these images, starting from the apical third, there was a lot of space between the root walls of the root and the obturation. The apical region not obturated. This continued up to the middle and coronal third. So this was the reason that she had all these complaints with this tooth. This tooth has also caused the sinusitis we mentioned earlier, because the obturation did not fill the endodontic space completely. Today, we will see how to avoid this problem with a modern bioceramics obturation sealer and a simple technique. The latest innovation that has occurred in the field of endodontics is the advent of biocements, which have brought about major changes in endodontics. Many studies have been done about bioceramic sealer, such as the ability to see accessory canals, physico-mechanical properties, and volumetric change of biosealers, and many other studies that have highlighted the fantastic capabilities of these biocements. I suggest to you, please read some studies and information about the biosealers before you use it in your daily workflow. Some of the most interesting studies conducted by Zhang and others can be seen here. The studies show antibacterial abilities of the cements, biocompatibility, and many other abilities like superior bonding, excellent flow, and so on. This table shows that comparison of BC sealer with other cements, specifically resin-based cements. The diagrams clearly show that BC sealer has better results than all the other products. Total Fill BC sealer is a calcium silicate based sealer. Here I will mention some characteristics of the cement based on the studies we mentioned earlier. The cement is a ready premix and comes in the form of a syringe, has antibacterial, biocompatible properties, osteogenic ability, has very good bonding properties with dentin as well as with filler materials, and is hydrophilic. This means if we have not managed to dry the canal 100%, it will not present a problem with these cements, as well as many other fantastic abilities that characterize this cement compared to other cements. Now let's see the clinical protocol of obturation. Here we have gutta percha, BC sealer in the form of a syringe with an application tip. BL alpha is not a must but can simplify cutting gutta percha BC points, and condensers to condense the BC point after cutting it. With BC sealer we can apply the method of single cone obturation technique. Other methods are possible as well, such as warm vertical obturation, carrier based technique, and so on. For most cases, single cone is best, simply and fast technique. And now I will present a clinical case where I will summarize what was said above. Here we have the lower right first mandibular molar with a deep filling which has resulted in an acute pulpitis, and the tooth had to be treated endodontically. In the first step we opened and designed the endodontic access cavity. Then we prepared the glide path, in this case manually, using K-file ISO 06, 08, 10 and 15. Also to this step was determined the canal's length. In the second step of this clinical case, we did the chemomechanical preparation of the canals with XP-endo Shaper and final cleaning and activation with XP-endo Finisher. It is very important that when using XP-endo Shaper and Finisher that the cavity is always filled with irrigant. And finally we performed the obturation. The first step here is of course the fitting of BC points. Then we use the total fill BC sealer syringe and the elastic application plastic tip to inject BC sealer into about two-thirds of the canal length. We remove the application tip from the syringe, cover the BC point in the tip with sealer, and finally we insert the BC point into the canal by making some slow movements inside, out and rotating the point in order to distribute the cement into all possible spaces within the canal. We cut the gutta percha with BL alpha and clean the cavity with a microbrush and water. And here we have the final radiograph where it is clear that the obturation has filled all the pre-prepared spaces with XP-endo Shaper 3-dimensionally. As you can see in this clinical case, the three-dimensional concept of chemomechanical preparation, cleaning and irrigation, as well as obturation of canals has been applied. And now let's see a clinical case of obturation with BC sealer.